examination for Form D aspirants. Organized by RX Doctors, organizing partner SDA Premier Clinical Research Institute, powered by EWTI Overseas Educational Career Consultant, Radiant Health Training Center. Our esteemed educational partners, Vagdevi College of Pharmacy, Tugari Veeramalappa Memorial College of Pharmacy, Bellary, Jayamukhi College of Pharmacy, Akshaya Institute of Pharmacy, Sri Abhirami College of Pharmacy, Seven Hills College of Pharmacy, KLE Academy of Higher Education and Research. Once again, welcome you all to this amazing session today. And it's a welcome back to everyone who have been sticking with us for the first days one, 2 days, six. So it is not going to disappoint you as might you get the glimpse of what is going to happen in today's session. Let me remind you that today we are going to have three speakers, eminent speakers. Dr. Hanish, who will be speaking about from the risk to resolution, root cause analysis in clinical pharmacy department. And the next session will be by Dr. Aaron Joseph, RX remote role of CP in telemedicine. And the last session will be by Dr. Apta Devi, who will be speaking about life as a UAE pharmacist, an essential insight in migration guidance for Indian pharmacy students. So please do stick around for having a great insight about everything. So as of now, from the day one, we've been talking about the different domains in which PharmD and any pharmacy graduates can step into, and what are the pathways we do have which are given by our seniors and the pioneers in this entire way. So, might have got many informations about how, where, and when to apply, and such informations. And today is also going to be one among them. So, with no further ado, let's move on to the first session. Let me take the privilege to introduce our speaker. So, we are honored to welcome Dr. S. Hanish, a distinguished clinical pharmacologist and medication safety officer at KIMS Hospital, Kurnool, Andhra Pradesh. Dr. Hanish brings focused enterprise in infectious disease, antimicrobial stewardship, and medication safety. At KIMS Hospital, he leads critical initiatives in infection management, including real time antimicrobial guidance, comprehensive antibiotic audits, and daily multidisciplinary rounds in high risk units such as ICUs and oncology wards. He plays a key role in institution wide AMS strategies by promoting resistance containment, de escalating protocols, and adherence to international treatment guidelines. Dr. Hanish bridges the gap between pharmacokinetics, pathogen specific pharmacodynamics, and infection control practices to ensure optimal and individualized patient care. He is a member of the Society of Infectious Disease Pharmacists and the American Society of Clinical Oncology. His academic contribution includes six peer-reviewed publications in infectious disease pharmacotherapy and clinical pharmacology. Dr. Hanish has presented impactful research on bioreactors, pancreatic cell transdifferentiation, and antimicrobial stewardship in Indian healthcare settings. His dedication has earned him accolades such as Best Poster Presentation Award at KIMS Hospital and the Best Research Idea Award from JSS Research and Institute Innovation. So please join me in welcoming this passionate clinical leader and advocate for safe and effective antimicrobial use who is going to speak on the topic of from risk to resolution, root cause analysis in clinical pharmacy department. Dr. S. Harisa, we are welcoming you to this amazing session and the stage is yours.
Thank you for a good introduction to me. And so we'll go for the session now.
Yes, sir.
Yeah, this side can visible now.
Yes, sir, it is.
Hello. Yeah. Good evening, everyone. This is Dr. S. Anish, clinical pharmacologist, and also your friendly neighborhood medication safety officer. Yeah, it's my job. You heard it right. Clinical pharmacologist and medication safety officer. What we will do in our hospital is we will catch all the problems in the hospital, everything. In short, we can say like we are like CCTV footage for all the medicines. I can tell you one small example. Like in one of the ward, I have seen the two nurses fighting with each other. So what's the problem in the situation is? So one nurse is telling like I have given the medicine for 6 a.m. So another nurse is telling like I gave the medicine at 5 a.m. So both of them have given the extra dose. So, and the patient is looking like he's feel like, am I overdosed? No. So the problem here is not blaming to each person of any nurse of any of the person. It's like we have to change the system. So in the situation, they need something one root cause an analysis, and there should be a kappa, that is corrective action and prevention action. So this is a topic about me about from risk to resolution root cause analysis in clinical pharmacy department. And so before starting with the introduction, so I would like to go with one clinical example. A missed dose, a case changed everything. So what happened? Here we'll see the one clinical case. So the patient, Mr. Ravi, 64 years old, admitted to ICU after heart surgery. On day 2, he got a serious infection with a septic shock. Doctor ordered meropenem injection, a strong antibiotic, to be given immediately. But the first dose was not given on time. Nurse couldn't find the medicine in the drug cabinet. Pharmacy had run out of the stock. And doctor's note was written after pharmacy working hours. The night staff thought it was already given. No one confirmed if the injection meropenem was given or not. So finally, the dose was given 8 hours late. Means almost the dose has missed the drug is missed at the time. So here, what went wrong? Already the patient is in septic shock. There is a serious infection. So the infection got vulnerable more. It was more worsen, and patient needed more medicine and ICU support because it is an infection. If we assume any antimicrobe, any pathogen present in the body, it multiplies rapidly. So here 8 hours doses not given. So microbes may be causing severe damage to any of the organ or any of the system. So patient needed more medicine and ICU support, and the patient stayed longer in the hospital. And family asked why the antibiotic was delayed, and hospital was asked to investigation the error. So if you see the total clinical scenario, whose mistake was it? Either the nurse or the pharmacist or the doctor. We can say it's totally a system error. So we have to correct something is missing in this clinical scenario. So we have to find the error. Hello, hello.
Yes, sir.
Am I audible?
Yes, sir, you are.
Yeah. Yeah. Whose mistake was it? The nurse, the pharmacist, or the doctor? The total system was wrong here. So blaming people is faster, but fixing the system lasts longer. So as I showed previous example, it was a missed antibiotic dose. And what happened? A nurse didn't give the patient their first dose of an antibiotic on time. So what will be next reaction? Fast blame reaction can happen. Supervisor have scolded the nurse, warning letter is issued, nurse became afraid to report future errors. Next week, another nurse makes the same mistake. So what the lesson we have to gain from this scenario is quick fix is no real solution. So now we'll start RCA approach. RCA is root cause analysis approach. It is the fixing the system. And root cause analysis showed here is no clear written process for who gives stat dose at night. Pharmacy did not inform about delay. Start orders were written in EMR, but nurses didn't give real-time alerts. And system fixes. We can create a stat dose SOP, standard operating procedures, and trained all the nurses, and added alert pop-up in EMR for stat meds and night duty pharmacy assigned for emergencies. So if you see in detail in this situation, EMR, it is an electronic medical record. So most of the hospitals it will be like a paper-based system. So if the EMR is live in all the hospitals, so everything will be in proper and accurate manner. Because at 6 a.m. dose, the patient will be getting the 6 a.m. dose, and the pharmacist will dispense the right medicine, and everything will be the proper procedure. And what are the outcomes with this approach is missed doses trapped dropped by 90% over 3 months. And blame fixes a moment, RCA fixes the future. And what are the objectives we will see in this scenario? So objectives, what we'll see here. So in this session, we'll see how to understand the importance of RCA in the clinical pharmacy, explore types of errors and near misses in pharmacy practice, learn the structured RCA methodology, that is a fishbone model and 5 whys, and case-based application of RCA, action planning, implementation, follow-up, and finally integrate an RCA with NABH and patient safety goals. It's not about the problem with NABH or JCA. Both the accreditation, NABH and JCA, they request about RCA. Why they request RCA? Request RCA means they need it because even though the Wi-Fi is not working, the pharmacy is not proper, totally bloomed up, everything, they need RCA. Whatever error happening, they need the RCA. So we will the process how RCA will be started, how system works here. So first of all, what is root cause analysis? This is the definition which I had taken from WHO and NABH guidelines. So root cause analysis, it is a structured, methodical approach used to identify the underlying cause of error, events, or system failures with the goal of preventing reoccurrence. So it mainly focus on why the event occurred and not who caused it. So whatever the reason, any causes which can occur in the hospital, so we have to find why the event occurred. And official guideline references I have mentioned here, WHO. It is a patient safety curriculum. The NABH 6th edition, it is a very updated edition. Patient safety indicators, that is in chapter 3, management of medication. And JC accreditation standards, Sentinel event policy. Sentinel means it is a death. ISMP, Institute for Safe Medicine Practices. Here, root cause tools for medication errors. So the main objectives of RC with examples we will see in this slide. So first thing we'll see here, prevent reoccurrence. So the main goal here is we have to avoid the same mistake in the future. Okay, let it take any example. At right now, something on dose error happened in the ward. So the same dose error should not be occurring in the future. That is the main aim of the RCA. Here an example, wrong insulin type given. So RCA showed look-alike vials. And so what we had to do here is we have to change the labels and Lhasa shelf system created and no further errors. And most of the hospitals will be seeing like crash cart. In crash cart, you will see many compartments, compartment 1, 2, 3, 4, and some shelf. So in that, for each compartment, there'll be separate medications, like look-alike, sound-alike drugs, and higher emergency drugs, and we have to label them red if a high emergency drugs present in the compartment. So so this is about prevent reoccurrence. So second topic is about understand what really happened. Here main goal is go beyond surface level error. In second topic, understand what really happened. Here main goal is go beyond surface level error. RCA revealed. So in root cause analysis, here EMR order and paper order both are active. But here pharmacy system updated to block duplicate routes. So this is the main error in many of the hospitals. So what happened in many of the hospitals, they'll be using both EMR and the paper order. So in paper order, they'll be medication. So what happened, both the dual medication will be dispensed from the pharmacy. So with this, what happened? So maybe there's a chances of getting the duplication of errors. And third topic is fixed process and not people. Is this connected? Hello? Hello?
Yes, sir, you are.
Hello?
So can you hear me?
Yeah, I can hear. Is this connected or disconnected? Actually, can't hear anything this way.
So you are connected and we could see your
Hello?
screen too. It is clear, sir.
Yeah, okay. Second
Yes, sir, you're
point,
good to go.
what I told is delivered, right? Understand what really. Okay.
Yes, it is clear.
And third topic is the fixed process and not people. Third topic is fixed process and not people. So your main goal is you have to identify the broken systems. Let us take one example. Suppose a nurse missed the stat antibiotic dose. whenever the patient enter in the hospital, physician definitely they'll give stat medications. If nurse misses the stat antibiotic dose, what happened next? Here, what we have to do RCA. Uh, no alert in the system, and pharmacy was closed. And night pharmacist assigned and EMS start alert added. So here first root cause analysis. If stat antibiotic dose was not given, no one knows whether the stat medicine given or not. If we make one EHR, in EHR stat dose is mentioned. If the nurse uses the EHR and she have mentioned yes we have given the stat medicine, means it will give proper indication for the nurses and the consultant and even the for whole organization. So alerting system is also very important. In most of the hospital there is no EHR, so they'll be using paper based medications. So in this these type of errors may be possibly happen. And fourth topic is about protect future patients. And here main goal is stop harm from repeating. So example, KCL given IV push, it may lead to cardiac arrest. So for this root cause analysis, we have to generally what may happen is there is no proper standard operating procedure for KCL dilution. So not only for the KCL dilution, most of the dilutions in our hospital. Let us take one of the example is vancomycin. So vancomycin we have to give at least 2 hours infusion. But what then our nurses will do, even though the doctor prescribes injection vancomycin for 2 hours slow infusion, but nurses don't know the proper dilution, so they may give rapidly infusion. So what happened giving rapid infusion, it may leads to rashes for all the body, it may leads to redman syndrome. So if we make one standard operating procedure, if you made one standard operating procedure like a guideline and everything, so everyone able to use those standard operating procedure. Like for example, if you make one guideline for those higher emergency drugs and restricted antibiotics, if you paste it all over the hospital, so every nurses, if they start giving any antibiotic and any these higher medications, they will be like alert. Okay, I am giving this antibiotic, so I have to make sure everything should be in right one as per guideline. So here main thing here is SOP should be made and KCL restricted to ICU with double checks. And fifth one is promote safety culture. So here main goal is we have to create open and learning environment. Yeah, here example junior staff afraid to report near miss with heparin. And RCA team conducted safety workshops and reporting increased 3x. So here not only the junior staffs, here most of the duty medical officers and PG residents, uh, they will be making mistakes, lots of errors in the treatment charts. Whatever the physicians will be writing in the progress chart, there will be lots of errors in the treatment chart. For example, dose error, dosage error, route error, frequency error, and there will be units. Let us take heparin. The heparin dose will be 5000 IU. Mistakenly, they'll be writing like just 5000 U. Nurses, what they think, okay, U is also like zero. So they may be given the 50,000. So these is a very small errors, but the patient leads, it is heavy damage because 5,000 units is required for the patient. But if the patient gets 50,000 units, it is almost 10 times more than the normal unit. So these type of errors also can be happen. And so normal education providing for the duty medical officer, PG residents, and even nursing teams like shift by shift, so that we can reduce the errors and improve SOPs and hospital policy. This is the main thing. So their main goal is upgrading rules based on evidence. So recently NEIBH and JCA, they are releasing lots of standard operating procedures and policies also to create new policies in the hospital to reduce this type of errors. If you take an example, chemotherapy dose error in pediatric patient. So what root cause analysis we will do here? No body surface area calculation chart. So here chart included in chemo protocol, dose verified by the pharmacist. So here for any these type of error, for example, obesity patient, pediatric patient, an adult geriatric patient, or else hepatic and kidney renal injury patients. So for these patients, we have to give customized dose. For example, making calculation with the creatinine and for example, obesity, body surface area calculation, it should be maintained. So these charts should be included in all the protocols. And seventh one is find hidden system gaps. So here main goal is to catch unseen problems before they cause harm. So let's take an example, delayed blood transfusion. Here, main root cause analysis here in delayed blood transfusion is there is a miscommunication between the lab and nursing. Generally, it may happen. There is a miscommunication. So what we have to do here for kappa, we have to introduce color coded forms and SMS alert system so that there be communication between the lab and the nursing people. So if you take the example between here blame model versus RCA model. So blame culture and RCA model, definitely it may happen in blame culture. How means uh, if it is happen in the paper based prescriptions and everything. In paper based prescription, what happen if the nurse does any mistake, definitely the supervisor shouts on the nurse and will take uh, to give apology letter. Everything have to do. That is a blame culture. In RCA model is like something upgraded, like NABH JC upgraded hospital. Here, something there'll be some of SOPs and hospital policies and EMR protocols. So here, what they'll do in RCA model, if any wrong dose happen, they font too small, the chart should be redesigned. Let me take an example. If I go to any wards, if I found any errors in the prescription, so immediately I'll tell to the nurse, you have to change total treatment chart and you have to write fresh medications. Even if any scribble in any dose or any the drug or any route, they have to start fresh treatment chart. So this is the RCA model. In blame culture, nurse gave wrong dose. It is like warning nurse. They a delay in stock drug, pharmacy stock gap, and introduce backup tray. So this is what RCA says. RCA is like if any errors happen here, it should not be happen in the future. We have to fix the system. So this is about the blame model versus RCA model. And required by NABH, JCA, and WHO. What are the requirements needed for NABH? And what are the required needed for the JCA? And what are the requirements needed for the WHO? So NABH expectation was root cause analysis for sentinel events. And if you take an example, if wrong dose was given, RCA done should be within days and kappa should be recorded. What JC asks, JC expectation was say sorry for the disturbance. My network is too bad. Is this okay now?
Yes, sir, it is.
Hello? Yeah, okay. So what are the requirements by NABH, JC, and WHO? In NABH, the requirement was RCA for sentimental events. And here example, wrong dose given, RCA should be done in 7 days and kappa should be recorded. And JC standards, their expectation was safety alerts must trigger RCA. So in real example, if you see medication near miss, RCA triggered and alerts revised. And actually NABH and JC, they have set standards. So they have to do RCA and kappa. It's just a mandatory. If they don't do that, this RCA kappa, they won't give accreditation. And what WHO says, they promote just culture. RCA report led to team-based solution. It should be not blame. So what we have to take fingers and start asking the right questions. So why clinical pharmacy matters in patient safety? Clinical pharmacy is a safety partner at bedside. Many of the people they think clinical pharmacy is like just they're counting the medicines and checking the drugs present in the prescription or not, but it's not obviously true. What the clinical pharmacist will do in the hospital we'll see here. So clinical pharmacists don't just check prescriptions, they protect patients from medication related harms. So if you see preventing areas ADS is one of the very biggest thing in the hospital and even in ABH and even the quality meetings and any of the hospital meetings. ADS is the main crucial role. Let's see one by one. What is the ADR? Adverse drug reaction. So what it seems, some drugs can cause unexpected harms even when used correctly. There is a difference between ADR and adverse drug event. If you give everything a proper, definitely the reaction may comes. It is an ADR. If let us take one example, a patient with kidney disease was prescribed gentamicin. Gentamicin, we know it can cause kidneys. So what clinical pharmacist flagged it, and he did dose adjustment. So pharmacists know which drug needs dose adjustments in the liver, kidney, elderly, and the children. So the main role plays here is to preventing adverse drug reaction. As I told previously for vancomycin, as I mentioned previously, so vancomycin it leads to lots of Redmond syndrome. That is a common thing, but we have to prevent it and we have to fix that and we made the proper guideline for each patient, not for each patient, each category for neonates, for children's, and for adults, and for geriatric patients, for everyone. Even for we gave infusion rate and infusion time, everything we had made the guideline, and it's going as per the guidelines. And second thing, catching before they reach the patient. So what it means? So errors can happen during prescribing, dispensing, or administration. The treatment chart it starts from the pin of the prescriber to the administrator. So in between, there lots of errors can happen, like prescription error, dispensing error, administration error. Every error can happen. So we have to catch all the medication error before they reach the patient. Let us take one example. Doctor ordered insulin 100 units instead of 10 units by mistake. The clinical pharmacist caught it before it reaches the nursing station. So this is called a near miss, and it's a pharmacist's daily job to detect them. And if you go for another point, it's preventing drug-drug interactions. What it means? Some drugs, when given together, can increase risk of side effects or reduce each other effect. So let us take an example. Patient on warfarin was started on fluconazole. Yeah, warfarin is a blood thinner and fluconazole is an antifungal. So what clinical pharmacists did? Clinical pharmacists started combinations. And we also made one what are the drug interaction combinations in one SOP, and we have pasted all over the hospital, so that whenever prescriber starts giving these type of medications, and at least they'll change the time at the route by giving oral and another drug giving an IV, so that we can prevent drug-drug interactions. And another topic is that guiding safe dosing in special population. So guiding safe dosing. So what it means? So children, elderly, pregnant women, and patients with organ failure need careful dosing. We get the different type of dosing, but what the many physicians will do, they'll give same type of treatment to all the patients. So this leads to complications with regards to the patient. So let me take an example. So child with infection was prescribed acyclovir without dose adjustment. So what happened? The clinical pharmacist corrected dose based on weight plus creatinine. And previously, physician they have some of the structure format by giving the medical reps. So they'll follow those guidelines. But what happened for each patient, patient by patient, the dose adjustment is needed based on creatine values and lots of biomarkers. So clinical pharmacists, what they'll do, they'll adjust doses using the evidence-based guidelines. And next topic is educating staff and patients. So what it means, pharmacists train nurses, doctors, and even patients to safely handle medications. If you take an example, new staff didn't know potassium chloride IV push is dangerous. Before telling this example, I'll tell one real case example. So in our hospital, what happened means tablet aldactone. for 1 year baby, aldactone should be given after crushing and by diluting with the water.
So we couldn't hear you. So could you check on your connection? We couldn't hear you, and your screen is also isn't visible for us.
Yep. So reducing hospital costs and stays. So here we use AMS metrics like DDT, DOT, LOT. So here what we'll see is DDT defined daily dose, DOT days of therapy, and LOT is length of the therapy. So here DDT we will see the overall hospital antibiotic consumption, and also even we will see the hospital cost, how much happening in the hospital. And DOT, LOT we will see for the individual patient and even for the wards. So whether there is going beyond the antibiotic consumption or not, even for the hospital stays and the cost of each patients. So now I'll go for the example. So antibiotic stewardship by pharmacists reduced resistant infection in ICU, shorter stay, fewer complications, and the lower cost. So every prevented error is a saved rupee, saved bed, and saved life. And next topic is about the supporting inhibition accreditation goals. So what it means. So NABH and JCA require medication safety indicators and RCA reports. And clinical pharmacists, they play major role in these both accreditation things. I think those who are working as clinical pharmacists, we will be having regular quality meetings and PTC pharmacy therapeutic committees and hospital infection committees and even mortality meetings. Everything we will be having. So in every meeting, clinical pharmacists should have to attend and they have to do the presentations. Everything. So if you see the example, during NHPH audit, pharmacist-led intervention was showcased and accreditation with zero non-conformities in medication safety. And here in this NABH audit and what are the presentation we will do in the hospital. So for everything, if you are showing any error in the presentation, so we have to add one RCA and kappa. So what is the root cause analysis? And what we did for the corrective action, the preventive action. Let me take one example. So I'll take a small example. If it one of the nurse gave tablet azithromycin twice, doctor advised to give at OD dose, but nurse gave a BD dosing. So what happened? The patient got bloody stools. So what happened? Immediately they called the clinical pharmacist and they told to check what the medication is going on. So the medication chart was correct. The doctor advised azithromycin OD dose, but so after total investigation, what we found is the patient had took two doses, that is BD dose of azithromycin. So what is the root cause analysis? The root cause analysis here is the nurse. Nurse don't know proper thing about azithromycin, proper dosing about azithromycin. So she have given double dose. So what we have to do? Kappa, corrective action, prevention action. So in corrective action, we stopped the dose of instead of taking two dose, we recommended to give only one dose. And prevention action, we educated the nurse not to repeat the next time. So in this way, we have to present in the quality meetings and whatever the NHH presentations in the hospital. So why it matters even more today? We know modern medicine uses more drugs, more complex regimens, and more high-risk patients. And when do we use RCA in the clinical pharmacy? So RCA is not just for big disasters. It's for any incident that could harm or did harm a patient, even if by luck harm was avoided. So let us see what are the events occurs in the hospital and what are the RCA we have to do. So first event is the sentinel event. So what is sentinel event? So it is a serious unexpected event causing death or the major harm. Yeah. Example. Patient died after receiving potassium chloride as IV push instead of slow infusion. So what RCA here revealed? So nurse didn't know the risk. No warning label on the drug tray and no double check system. So here outcome is RCA led to policy change. Those who are in NABH accredited hospital as clinical pharmacists, they can see. So for everything, there is a standard operating procedures. So for every medication, there is something indication whether it is a red label or is a blue label, and we be sticking with regarding of LASA drugs, high emergency drugs. So every warning label should be mentioned on the each drug. So RCA led to policy change. High alert drugs now need pharmacist verification plus bold red labels and near misses. So an error that almost happened but was caught just in time. So let's take an example. So doctor prescribed 10 times overdose of heparin. It was caught by clinical pharmacist before administration. So patient was safe, but RCA still needed to understand. So why the doctor miswrote? Why system allowed such type of orders? It should not be happen generally. So what takeaway in this situation is, so near misses show weak points in the system, like warning systems and also not working, and medication errors. So any mistake in the prescribing, dispensing, or giving of the medicines will be coming under the medication errors. So let's take the wrong drug. So before take the wrong drug, I need to tell one clinical example which is happened in the real scenario. So what happened? One of the patient, 10 years old boy, came to the hospital. So one of the duty medical officer is it at 9 o'clock. His shift will be ended at 9 o'clock. So what happened? Immediately he gave injection paracetamol, syrup paracetamol, just 5 ml TAD. He returned and went. So what happened? He ended the shift and he went. So what happened? That hospital, the hospital is the adult one, not the pediatric one, but the patient is 10-year old. So what error is in the prescription was he didn't wrote the strength of the paracetamol. So strength is very important because paracetamol comes in two strength. One is 250 mg, another one is 250 ml, another one is 125 ml. So as it is not pediatric hospital, so the nurse did the same as per the treatment chart. So she thought the paracetamol was the 250 ml, and she went to the pharmacist and gave 5 ml directly to the patient. So what happened next day? The patient got nausea, dizziness, and complications have started. And next evening, they took one liver function test, and all the enzymes was elevated. So by the evening, uh, they have shifted to ICU. So the patient came with one small fever, but the complication is very severe. It just with the error of the strength. So these type of errors may be causes with minimal error maybe causes a big complication. So is one example, real example which I have faced. And second thing about wrong drug. So in this slide, if you can see an example, ordered chlorpromazine, but chlorpromamide given due to similar name, that is LASA error. So what RCA revealed? So similar looking packaging. and pharmacist absent during night shift. So what solution we have to do for this is, so barcode scanning plus shift time pharmacist coverage. So whenever the pharmacist is not available in the shift time, they have to immediately replace another pharmacist. So after proper verification, the drug have to shift to the ward. And wrong dose. Here one example, the patient received double dose of morphine due to duplicate chart entry. So what is the root cause analysis? So there is no communication between the ICU and the ward staff during handover. So this is very important. You know, most of the hospital wards, while changing, for example, one patient transferred from ICU to ward, so there will be handover to this another ward. So while taking the case sheet of that ward, the nurse have to verify everything, drug dose, route, signature, everything should have to check everything properly, because once it was shifted from the ICU to ward, the handover will be everything in the ward. So most of the nurses, they won't check everything. So just they will change from ICU to ward. So what happened? There'll be error in the ICU. The same error will be transferring to this ward. So what is the solution? So there should be introduction of standardized handover tool for the wrong dose. So missed dose. If you see an example, there is an antibiotic dose not given due to drug stockout in the ward. Yeah, this is very big problem. Antibiotic dose not given due to drug stockout in the ward. So what main root cause analysis here is, pharmacists didn't restock in time plus nursing staff didn't escalate it. So if the drug is not present in the pharmacy, they have to immediately they have to start they have to speak with the management. So if nursing staff knows about this issue, they need to escalate to clinical pharmacy or to the management, because if there is no drug of that for that person, so immediately they'll check the pharmacy stock, so which drug is available, they'll be administering the medicine. So what's the solution for this? We had to fix the solution. So what the solution here is, we have to add auto alerts in the inventory system and ADRs. When a drug, even at normal dose, harms the patient, that is true. As I told previously, vancomycin, if you give as per protocol, definitely the patient may get Redman syndrome. Because if any just minute infusion is also, it may lead to Redman syndrome. So for this, I have given an example. Patient developed seizures after receiving high dose penicillin tazobactam, 5% tazobactam with kidney failure. Of course, true. Peptide, the main complication is the seizure. So what is the root cause analysis here? So there is no renal dose adjustment, and there is a poor documentation of serum creatinine. So what the outcome here is, so should be adding the pharmacist checkpoint for renal dosing and mandatory serum creatinine documentation in drug chart. So these errors may be happening in the paper-based system. Paper-based system means the patient will be lying in the ward, and the total treatment chart will be in front of the patient. So sometimes it may be missing the treatment chart, and sometimes maybe missing the lab values. So if everything it is in EHR, that is electronic health record, so that physician can easily pop up everything, serum creatinine, even in EHR, the dose calculations is also very easy method. So the physician can calculate the dose and he can give the prescribed personalized treatment for the patient. And OTC misuse or self-medication. So patient take non-prescription drugs wrongly and get harm. Let us take an example. So patient with heart disease took ibuprofen daily for back pain, landed with gastric bleeding. So main root cause analysis here is, pharmacy counter did not ask for comorbidities and no counseling. This is very big drawback in our India, not only in one hospital, all over India. So whenever any patient, if they go for the pharmacies, definitely they'll give whatever you ask. If you ask narcotic drugs, also many of the pharmacies they may be giving. So with this, what the outcomes we had to see here is, counters should be trained to ask two quick questions before OTC sale. So in hospitals, if any OTC sale is there, they have to ask basic questions, whether if you're having comorbidities, any drug allergies. So basic questions should be asked. And LASA, look alike, sound alike drug mix-ups. So drugs with similar names or packs get confused, obviously. So here on example I have mentioned, I'll tell another example. So what happened, one physician, he have advised tablet levi levipil to the patient. So what happened, the pharmacist, he didn't identify the levipil. So instead of giving levipil, he given levofloxacin. The brand name, it similarly looks both the brand Levipil and the levofloxacin. He given the levofloxacin, but nurse got doubt on the drug and immediately came to the clinical pharmacy department and asked about the medication. And what we did, so these both are totally different brands. So immediately we changed the drug and we have given to the patient. So in lookalike sound alike, these type of errors may happen. So now let us look in the slide that example. Instead of Gyloric is the composition with allopurinol. The patient received Gyrope, that is erythropoietin. So they have injected wrongly, leading to the high BP. As we know, uh, erythropoietin, it leads to more blood pressure. So what's the root cause analysis here? So drugs stored together and labels are faded. So what we have to fix the solution. So for this fixing, we have to mention clearer labels and Lassa drug list posted at the pharmacies and separate bins. So Lassa drug, it's not only posted at pharmacies, it have to mention each of the ward and each of the crash cart. Crash cart means we know, so higher at medication, everything will be present in the crash cart. So wherever the crash cart, where the pharmacies, where the medications in the ward, we can see their Lassa drugs and higher alert medication should be pasted thoroughly. And NABH mandate and RCA, why it's not optional. So we know NABH, it is a National Accreditation Board for Hospitals. It is a set of rules for hospitals to ensure patient safety and quality care. So here root cause analysis is a must do, not just a good to do. So let us see about what NABH tells about the root cause analysis. So in NABH chapter 3, the patient safety and quality improvement. So hospitals must do root cause analysis for every sentinel event, not only for a sentinel event. If any error happened in the hospital or any ward or any error with the patient, RCA kappa is mandatory. Because if NABH auditor came to the hospital, if you see any error, did you do RCA? You have to do RCA, definitely. If you don't do RCA, we won't do accreditation. So in this way, NABH deals with the hospital. And what is the use of QMS? It is a quality management system tools. NABH promotes structures tools to find, solve, and prevent problems. What are the tools used in the RCA? Fishbone diagram, 5 whys technique, Pareto chart, and FMEA. But most of the clinical pharmacists in quality meetings, we will be using mainly fishbone diagram and 5 why technique. We will see what is the fishbone diagram and what is the techniques used for quality management system. Encourages a reporting culture, not the blame culture. NABH says staff must feel safe to report mistakes or near misses without fear. Why? Because silent systems are the unsafe systems. Clinical pharmacists always they'll find the errors and they'll be presenting the quality meeting. So most of the nurses they will feel they are presenting something about regarding nurses or any of the person in the meeting. They will feel so they won't reveal any error if really happened. So what we will try to say is, okay, let it happen the error. We will fix it and we will prevent in the future. So we'll take one example. A junior nurse noticed that insulin pens were being shared between the patients. It is very infection risk. What did she reported it? Root cause analysis started. So found no one trained her on insulin safety. Saved future patients from harm. So what we get result from this example is new SOP made plus reporting posters displayed in the wards. So SOPs is a very important standard operating procedures for everything and posters displayed in the ward. If any recurrently happening any errors in the ward or any hospital, we have to make on standard operating procedures and we have to make the posters. It should be available how to see can see by all the nurses or any healthcare professionals. and audit this action is a mandatory. And most of the nurses or any doctors, they'll be telling what clinical pharmacists they are doing something audit. They're coming to the ward and they're taking mobiles and they're checking drug dose frequency, something they're auditing and something going. But what clinical pharmacists actually do, we'll see here. So NABH wants hospitals to track events like root cause analysis and to take kappa, that is corrective action, prevention action, and must show records of what happened, why it happened, what was done to fix it, who is responsible for the changes, and how follow up was made. Let us take one error or ADR happened in this month. So what clinical pharmacist will do? So he will go to that incident and he will do investigation of all the process and what happened in that incident, why it happened, what was done to fix it. Everything he will find the solution for that, and he will present the same thing in the quality meeting, and whole meeting will discuss about the situation we will do in future, how we will fix this, and in future if this happens, so how we have to fix that problem, and regular follow-up should be done. For example, fridge medications, we know in fridge there are a set of medications. There will be 5 to 6 medications will be present in the fridges. So what happened in the fridge medications, some of the medications will be expired because most of the wards sometimes they may be not using the fridge medications. So in that what happens, it may be leads to expiry. If really the drug is needed to the patient, if they give the expiry the medicine to the patient, what happens, the actual therapeutic effect we can't see. So regular follow-up of fridge medications is needed. I'm telling one example. So most of the follow-ups is needed in all the situations. So what are the steps in root cause analysis? The first thing here is find out what happened. Let us take one thing. Describe the event clearly. For example, a patient was given the double dose of insulin accidentally. Okay, patient was given double dose of insulin accidentally. So we have to find what happened. Means we have to describe that event. The double dose was of insulin was given accidentally. Next thing, so collect all the information. So talk to the staff, check prescription, notes, reports, shift timings, medication charts, everything. Here we take an example. So found that insulin was charted twice in 2 different places, and draw the event flow. So create a timeline as a flow chart. What happened, when, and who was involved here. And example, discover that night nurse and morning nurse both gave doses without checking. This thing, these type of errors is probably happening in many times, because night nurse will be giving and morning shift nurse they will be giving, so they won't check whether the means they won't document. Main thing is documentation. They won't document anything. They will feel night nurse have not given this dose, so morning nurse will be giving the dose. So we have to draw the event flow and look at contributing factors. So find all things that made this mistake possible. For example, if there is no cross check before insulin administration, staff missed daily medication review, and there will be poor handover communication too. And fifth flow is use RCA tools. As I mentioned previously, there are few tools for root cause analysis. That is 5 eyes, fishbone diagram. I gave an example. What is the 5 eyes? Why was I'm taking this previous example. Here I gave the example that patient was given a double dose of insulin accidentally. Now we'll make the example in the fishbone diagram. So 5 eyes. Why was insulin given twice? What is the answer? Two nurses gave it. Why did both give? Both thought it wasn't given. Why? No insulin record updated, and EMR system was down, power cut, and no manual backup. So these 5 ways will get main the RCA and kappa and find the root cause, the deepest reason why the error happened. Example, no backup plan when EMR failed, no one recorded dose manually. Yes, EMR, electronic manual record. There are most of the possible things in means positive things EMR, but sometimes there is a negative things also. Sometimes EMR you go for scheduled maintenance. In the scheduled maintenance, we can't able to use that EMR. So during those times we have to manually enter in our chart or any prescription chart. So if you won't enter those documentations, what happened? These type of errors maybe happen by giving double doses, by giving changing of the doses or any dilution errors. Many errors can be happen. And plan corrective and prevention action kappa. So here fix the current issue means what RCA we have done. So what corrective action we have to done for this, and prevention, prevent it from happening again. It should not prevent means it should not happen in future. And follow up and monitor and checking if the new process is working. So one error is happened. RCA we got means what the main root cause, and we have done corrective and prevention action. So the prevention action we may be making new model for future use. So there is a new process we have started. So we have to check whether the new process is properly working or not. If that is working, we have to audit regularly, and we have to ask for feedback with any nurses or any DMOs or any person. I gave an example here. The pharmacist audit after 2 weeks showed no more insulin duplication events. And what we have to take line here is RCA is not about the pointing fingers. It's about pointing out what the broken and what's fixing it. So this is one fishbone diagram. Here, equipment, process, people, management, environment, material. So so here, if any error happened with regarding to the equipment, so we have to mention all the things in the equipment. If any error happened with regarding to process, we have to mention about the process. If error happened due to the nurses or any other person rated, so we have to mention people. If any error happened due to the management, we have to enter in this management section. If any error happened due to environment, for example, let us take ICU situation. In ICU situation, they may be giving oxygen or any. Let us take oxygen itself. If any power got blocked and means power got damaged or any environment is not properly good, so all the errors will be keeping in this environment and materials. So now we'll see by case, like one example, like wrong dose, missed dose, everything. So first thing is wrong dose given. Example, a patient received 40 mg of enoxaparin instead of 20 mg. So what is the root cause? So handwriting was unclear. There was no system to double check the dose, and pharmacists didn't verify. So what corrective action we can do here? So patient was monitored for bleeding. The error was reported and documented. And what preventive action can do? Implemented a policy that all anticoagulants must be double checked by a clinical pharmacist, shifted to computer-based prescribe to avoid mislearning. Yeah. So in this case, a patient received 40 mg of enoxaparin instead of 20 mg. Almost 50% of 50 mg of dose is not given to the patient. No, 50% of dose has given to the patient. So here main root cause is uh, maybe DMOs or any consultants. Maybe the handwriting was not clear. So nurse have understood their instead of 20 they have given 40, and pharmacists also didn't verify. So what corrective action we can take? The error should be reported and documented. And prevention action here. So here the problem is with enoxaparin. So we will make one anticoagulant policy. So with this policy, whenever enoxaparin they are administering, they have to do double check by the clinical pharmacist. Sometimes they may be giving indent by the clinical pharmacist so that they may be reducing of the dose errors. What is the missed dose? Let us take one example. So antibiotic dose was missed during the nurse shift change. So what is the main root cause here? So as we know, there will be 6 hour shift for the nurses. So what happened after finishing the one shift nurse? So there may be no proper communication regarding the handover. So what happened here? Medication chart was not updated. So main thing here, corrective action here is the dose was administered late and the physician was informed. What is the preventive action? So introduced EMR, that is electronic medication records. So checklist during nursing handover and the daily pharmacist dose audits and duplication dose. So let us take one example. Two nurses unknowingly gave the same insulin dose 30 minutes apart. So main root cause, what we found here is a poor communication between the shift and insulin chart not signed after first dose. So the corrective action we can take here is patient was monitored for hypoglycemia and event was documented. And preventive action started using a dedicated insulin administration chat and visual alert sign for higher rate medication, trained staff on insulin protocols. So with this, root cause analysis kappa, we can reduce duplication doses also, and wrong dose dispensed. This is the Lassa error, lookalike sound like error. So let us take an example. Hydroxygen was dispensed instead of hydralogene. Yeah, hydroxygen. These lookalike sound like drug, and but both are different drugs. So here main root cause here is there is a similar looking names and packaging too, but there is no barcode scanning. So what we can do corrective action here. So check the patient vitals and replace the correct drug. Prevention action. We have implemented LASA stickers and Tallman lettering. Example, hydroxygen and hydralazine. So if we make Tallman lettering in both of the drugs, so the pharmacist can easily identify the drugs and can dispense in the pharmacy. And when it comes to the nursing also, the nurse can identify so both of the drugs are different. It's not like similar. And barcode scanning made mandatory before administration. Because in barcode scanning, we can identify the drug which is similar or not dissimilar. And delayed administration. This example, as I had told previously, I had took example blood transfusion was delayed by 2 hours. Your main root cause analysis here is lab didn't inform nursing on time and there is no alert system for blood ready notification. So what corrective action we can take here? So blood was given, delay was reported and discussed with the team. Preventive action. Okay, error was happened. We have to prevent it for future because another patient should not get happen with this error. So what preventive action we can take here is we have to introduce SMS alert system when blood is ready and color coded blood request forms and transfusion time monitored by the clinical pharmacist. And OTC misuse. Example, patient continued taking diclofenac for post 7 days post discharge without advice. So what's the problem here is the patient has taken the diclofenac for 7 days after post discharge. Actually, it's not recommended because it is like misusing of OTC drugs. Because no one questions if you go directly to the pharmacy and if you ask about OTC, they'll give immediately. So the main problem here is root cause analysis, no counseling at discharge, patient unaware of risks. As we know, paracetamol is a OTC drug, but the main error, the main problem with the paracetamol is it causes liver damage. But if we don't give proper counseling at during discharge times, the patient may take for 30 days or two months. Maybe he may be more what we can say most proper healthy. So what corrective action we can take? Patient was called, counseled, and started on stomach protective medication. So what preventive action can take here is discharge medication counseling made compulsory, provided
Sir,
written patient is. Yeah, tell me. Hello.
sir, really sorry to interrupt. There's our time is
Okay.
defleeting. Like we have to stick to the schedule. Could you rush a bit, sir?
Okay. 1 second.
Okay, sir.
Just have. Okay, I'll tell. I'll finish in 5 minutes. Okay.
Okay. Thank you.
Okay. So next, adverse drug reaction, drug interaction ignored. So here also there is a root cause analysis. We have to find the error and we have to do kappa and expired drug dispense. As I told previously about fridge medications, expired drugs we have to do follow up daily basis or monthly basis, and inappropriate dosing in renal patients. Here, root cause mainly is mainly creatine levels will be it should be checked properly, and kappa should be EMR alerts for high creatine levels. And wrong patient received medications. Here, generally wrong patient means if patient having the same names, they may be getting the wrong medications. Here, kappa should be made double check process, and they have to give and they have to make a barcode system and medication not available. Generally, stock out medications maybe happen in the all the pharmacies. So here also root causes we have to find and we have to make emergency buffer and corrective action. Alternative drug should be given, and preventive action here, minimum stock collection should be added, and pharmacy buffer stock policy should be initiated. And here also clinical pharmacists include in the purchase committee. So here we can see clinical pharmacist role is very bigger in the hospital. Wherever the medication present, the clinical pharmacist should be present there. Yeah, thank you.
Thank you so much,
Hello.
sir. Guys,
Yeah,
if you
thank you.
have any questions, please put it down in the comment section. As because you have to stick to our schedule, we'll pick one questions, and for others, I expect that Sad to answer it in the comment section too. And I guess that is was crystal clear to everyone. Thank you so much, sir. Thank you so much for your presence. It was a lovely presentation. Thank you so much for completely decoding everything that happens in the hospital sector and how to prevent those errors and for the betterment of our clinical pharmacy practice. Thank you so much for your presence, sir. We are really grateful to have you today.
Thank you so much.
And yes, you guys, let's move on to the second session of today's. Our speaker is going to be Dr. Aaron Joseph, clinical pharmacist and in charge Department of Telemedicine, Believers Church Medical College Hospital, Kerala. So let me take my privilege to introduce our speaker. Dr. Aaron brings hands-on experience from reputable institutions, including Believers Church Medical College Hospital, Kerala, with clinical exposure in departments such as neurology, endocrinology, and general medicine. He has demonstrated a strong command in patient counseling, drug monitoring, ADA reporting, prescription audits, medication reconciliation. Beyond clinical practice, Dr. Aaron has also contributed to the academic community through publications on bacterial meningitis and innovative drug repurposing strategies. He has completed multiple certification courses in ECG interpretation, hematology, gastroenterology, and antimicrobial stewardship, and actively participated in numerous national and international conferences on infectious diseases, AI in clinical research, and pharmaceutical advancement. Dr. Aaron is also recognized for his leadership and achievement, having secured the Best Social Media Manager award and holding university level ranks across pharmacy subjects. And today, he'll be speaking on the topic of RX remote role of CP in telemedicine. So please join me in welcoming Mr. Aaron Joseph, a future ready clinical pharmacist committed to advancing patient care and public health. Welcome, sir.
Hi, all.